Samari from Croaky here again, and we're at the inaugural World Indigenous Cancer Conference in Brisbane, and I'm about to talk to Lisa Whop, who is a researcher at the Menzies School of Health Research, about two reports that were published today that are landmark reports for you and in Indigenous health. Can you tell me what they were, where they were published, and what they're about?
Yeah, sure. So the two papers published today, the first paper was regarding Indigenous women and their participation in the cervical screening program using Queensland data, and that article was published in Cancer, International Journal, and the second paper was a paper looking at, of those women who are screening, what are the differences in abnormalities between Indigenous and non-Indigenous women, published again on the Public Library of Science 1.
And what have you found in both?
So just starting with the participation, we have found, and this is in the context that cervical cancer incidence and mortality is much worse. Survival is much worse for Indigenous women, and we really know nothing about how Indigenous women have integrated, or how they have been involved in the National Cervical Screening Program. So what we have found is, which is the first population-based comprehensive report, that Indigenous women are significantly less likely to screen in the program. So two-thirds of Indigenous women in Queensland don't participate in cervical screening, and we found that of the women that actually do screen, they have much higher rates of cervical abnormalities. So those are the two big findings, I suppose, from both of those papers.
And why didn't we know that before?
Good question. The reason why we don't know is the pathology report forms that are the main data source for pap smear registers. So when you go and have a pap test, the doctor sends off a lab report, and the lab report gets records on the pap smear register that this woman had a pap smear and these are her details. And so on those forms they don't identify Indigenous women, and this has been a known problem. So it's not that we just realised yesterday, we have known about it for a very long time, and nationally we don't have that data. So despite the major success of the current screening program that has seen a 50% reduction in incidence of cancer for most Australian women, we actually haven't seen that at all for Indigenous women.
And in fact, there's been no improvement over a long time.
No improvement. So in terms of participation, there has been no improvement over time. Yeah.
So you resolved to fix this over a Lamington, you said today.
Yeah, I'm pretty sure it was a Lamington. We held, Gail Garvey, who's one of my supervisors and heads up the cancer research group at Menzies, thought it would be a good idea to bring all the people around the country that were doing something about cancer. Until that point, we're pretty working in isolation and have a conversation, and at that meeting I got to meet Professor John Condon, and we were talking about cervical cancer and just the fact that it's a national shame that you can't identify Indigenous women, and this is something that we have hard evidence that screening will prevent cases of cancer. Screening will save lives. Most women in Australia now that are diagnosed with cervical cancer or die from cervical cancer have not had a pap test in the previous 10 years, or never at all. So we sort of know where we should be placing our efforts. The difficulty is that the program hasn't been able to record it, and there's been much discussion about how that could be overcome, but very little action. And so John's idea of record linkage was the first of its kind.
And without going into too much detail, no, not at all. Everybody said it actually was quite a job to link that. Can you sort of give the non-nerds amongst us a bit of a
yeah, so basically we had one data set where we wanted information, but we didn't know who was Indigenous. And we had the hospital data, which does identify Indigenous people quite well, with massive improvements in how they've done that. And we linked them through a very technical probabilistic record linkage methodology. And the actual linkage, it's a process, but it's not difficult. What was difficult was actually getting the data released and the time it took to obtain that. So we actually got ethics approval in November of 2011, and it took 19 months for everything to be approved before we even could start linking the data.
Now, the news release that went out about this today said there's been no improvement in rates for Aboriginal women. In effect, it confirmed what you always thought. What's the significance of being able to do that?
Yeah, so that's true. We knew from the outcomes of having cancer, Indigenous women dying from cancer or having late stage diagnosis in particular is a big indicator of low participation. And from really small localised studies or communities that participation wasn't that great. But what we didn't know was any information from the actual screening program. And so I think what makes change and what policy makers want to see is an evidence base. And so it's very difficult to implement any strategy if you don't know how to measure or you don't even have a baseline. And I think that, for me, that's been the one thing I've kept coming back to is, well, you can do a program that might increase screening for a period of time, but how do you know it actually worked if you can't tell what it was in the beginning? So the reason this is such a landmark paper is because both of these papers use population-based data from the program itself.
For the first time?
For the first time,
yeah. Does it give us any sense of why those screening rates are so low?
Not... I mean, it gives us a sense that they're low, and I think that provides, a sobering thought, and it really pushes for action now, especially in light of the new screening program to take off next year, which essentially has been decided without any real concrete knowledge of how Indigenous women screen, which are one of the populations that need to benefit the most from the renewed program. Otherwise that just creates further disenfranchisement. Yeah.
You said that when it launches, it's 1st of May next year, isn't it?
Yeah.
Can you tell me, what's different about it? And you said today it's a real opportunity now.
Absolutely, and I think that sometimes those opportunities are rare, that we get, the chance to, in a sense, start fresh with a new program. So the current program is a 2-yearly pap test for women aged 20 to 69. The renewed national program, which has been based on a global evidence base of how we test for and screen for pap tests now, for cervical cancer or for HPV, which is the virus that causes cervical cancer. And we see that the 5-year, so it'll move from a 2-yearly pap test to a 5-yearly program, HPV test, and it will be for women aged 25 to 70 with a 4-year exit screening.
And what would you like to see that it does now?
Number one, it absolutely must report Indigenous status, the ability just to be able to record it is only one facet. It means that patients are willing to identify, it means doctors ask the question, it means it's recorded correctly on the pathology report form. So it's not that you can just point at one person or one group and say it's their fault, but I think if you have that overarching expectation that we expect Indigenous status to be collected, then that provides a precedence for taking it seriously and making real change in the community.
And has there been an approach for that to happen?
So there I am told that there is, it's definitely one of the key topics for the renewal. Apparently tomorrow at the breakfast session there's going to be a discussion more about Indigenous women and the renewal. I'm not sure necessarily about the data collection. Currently the renewal suggests that there will be an improved data collection system for Indigenous women and culturally and linguistically diverse women, but I'm not quite sure of the detail of that.
One final question. You said, as a policy nerd, a data nerd, that you were strapped on your Fitbit when you got up on stage to present in order to monitor your heart rate throughout. What were the findings of that?
Well, I really wanted to time my talk, but I spoke for 17 minutes and 3 seconds, and of course at the beginning it was quite high, and then by the end it had sort of come back down until resting heart rate.
And lessons from that?
It all gets better in the end.
Thank you very much.
No worries.